Before we go into details, let's briefly review coronary disease. And the best way to think about it is, okay, this is your vessel. Your heart also needs some vessels to supply it. I don't have to bore you. This different size, different type of artery. They have names. You know, there's right coronary artery, the left, the LDL, left anterior descending, all of them. It doesn't matter. Okay, you have a vessel, and sometimes you can form plaques. It's the same. Coronary disease is a form of vascular disease. So you form plaques from cholesterol. Okay, and that block it impede flow of blood through the vessel. The heart, like I said, also need blood supply. So if there's blood supply going to the heart, or if there's a decreased flow, every tissue in the body, when you don't get oxygen, so lack of oxygen and lack of blood, which is equivalent to lack of oxygen, they undergo what we call ischemia. That means tissue is going to start dying. If the ischemia prolong, that's when they start having pain, and the ischemia prolonged for a long time, the tissue completely die, necrosis. So you don't want to get here. So usually when the blood flow, it can decrease a little bit, and you start having chest pain, back and forth, chest pain. And that intermittent chest pain that you get from ischemia is what we call angina pectoralis, basically chest pain due to ischemia. So there's a decreased blood flow. And then that is causing the pain, leading to the pain is ischemic pain. So that's a B-sharp pain. You're going to lose your life. It's a priority. You have to do something about it. So the ischemia kind of pain, a pain that you can lose your life. How would that pain? What kind of pain will give you ischemia? From somebody who have coronary artery disease, the blood flow is already almost about to be cut. Well, if there is an increased oxygen demand, so number one, increase oxygen. So you need more oxygen demand, or decreased supply of your oxygen. Okay, that can give you this problem. You start having chest pain. And an example is like what? If you exercising, sometimes if no exercise for a long time, you start running, you see that your chest start hurting because there's less amount of blood going into your heart. So it gives you some ischemic pain. The tissue is requiring more oxygen than they needed for you to sustain that kind of energy, or that kind of demand on them. So that will lead to that. Another thing is if you're having sex. Sex is another form of what we call a lot of oxygen demand. You require a lot of oxygen demand to do that. If and that can give you chest pain. That's why some older people, they can have a heart attack when they're having sex, because there's a lot of oxygen demand associated with that. It can also be from if your emotion changes. I know sometimes when you become anxious, and then your anxiety increases, you are afraid of something, and your hormones, epinephrine, or secreted because you're scared, that can also give you some ischemic kind of pain. Okay. Another issue is temperature. Temperature too. Changes in temperature can give you ischemia, especially if it's really cold. Cold temperature causes vasoconstriction, and that can make the artery clamp down, and that can give you ischemic kind of pain. Okay, that can also do that. Sometimes when there's too much vasodilation, also not even vasoconstriction, and that happens when there's heat. So when extreme heat, so warm heat, temperatures can also give you heart and some ischemia, chest pain angina pectoralis because it causes too much vasodilation and blood doesn't go back to the heart. So not just extreme cold, extreme temperature, heat. Number 4 is I think other chemicals. I'll group them as other chemicals like tobacco. When you smoke can cause vasoconstriction, and then notoriously the bad one is cocaine. Cocaine. So if they give you a question on SATA, on a priority patient, any patient who is taking cocaine, and they ask you to see them as a priority, cocaine is number 1. It causes ischemia. So they will get ischemia of their gut, bowel ischemia or coronary artery ischemia. So they can have a heart attack or a tissue in the abdomen will die. So if I were you, if they give me a question on a cocaine, I have to make sure it's not about pain. Any cocaine patient who taking cocaine and having pain in the chest or the abdomen is a priority patient you have to see because it causes severe vasoconstriction and decreased blood flow, and the tissue will die. So cocaine is like catecholamines, basically do the job of a catecholamines. And so that's what can do that. The other risk factors I'm running out of, number 5 is basically they have coronary artery, what we call spasm. So there may be spasm of the coronary artery, and that is causing the ischemia. So for angina pectoralis, and so these are the things that can cause the ischemia, okay, all day. So that is the definition of angina pectoralis. You can divide them into stable and unstable. Stable means they only get a pain when they exert themselves. So exertional pain. But when they have the pain, what do you think? They stop. And then the pain get better. It's like claudication, the same thing. Think about it. You don't have to isolate it. Claudication. So the other way to remember it is, when patient has claudication of their leg, when they walk and they have a pain in the calf, then when they stop, pain get better. That is another vascular disease. Coronary disease is the same. It's the same vessel, but it's near the heart. And so stable angina, another way to see it is, say, it's claudication of the heart. Basically, when you exert yourself, you start running, you've never run before, you're exerting yourself too much, you have pain. As soon as you stop, the pain get better. So that's stable angina. That's what it means. It doesn't mean when you run and you have chest pain, you're getting angina. This is patient who have coronary disease. The vessel is already blocked. I'm just using it as illustration so that it's some way to understand what I'm trying to say. So if this is the vessel and then they already have some plaques there in the vessel going to the heart, so when they're exerting themselves, the plaques get closer. I mean, this squeezes a little bit less blood going, but there's still some blood going. The amount of blood going is smaller than what usually go, where there's something passing through, and that's when they get angina. And when they stop, the artery open better and the blood flow get better. Okay. Unstable is really bad. That means they don't have to exert themselves. So there's no exertion at all. No, they can be sitting down and they have chest pain. They having chest pain. No matter what, they sitting down and having chest pain is unstable angina. That means that's almost getting closer to the vessel is getting closer from closing completely and causing something we call heart attack, basically myocardial infarction. So theirs is almost about to close. So when they're sitting down, they still having pain. The last one, and just to be familiar with them, Prinzmetal is another coronary disease that happens. It's not truly coronary disease, but these people, their vessel go into spasm. So you go into spasm like that, and that causes blood flows to decrease. So blood flow going to the heart, it decreases. but there's no plaques. There's no plaque. I'm using this to show there's no plaque. So blood flow going to the heart decreases. They don't have plaques. It's just a spasm. So they have normal heart vessels, but they go into spasm. So this is what we call Prinzmetal type of angina pectoralis. So they don't have plaques. So that's the distinction between stable. Stable means exertional chest pain, unstable non-exertional chest pain, and usually occur at rest. And Prinzmetal is basically spasm of the vessel. There's no atherosclerosis happening there. You have to know, I don't want to talk about it. If you look at my other cardiac lecture, you see the problem. Atherosclerosis means all this is coming from atherosclerosis. So basically, you have cholesterol building up, and then blood flow forming plaques. Blood flow is decreased. And they can ask you some of the risk factors of cholesterol building up or developing coronary artery disease. So hypertension for sure, smoking, okay, diabetes, okay, cholesterol, hyperlipidemia. And then these are the common 4 things. You should be easy to list them. So hypertension, smoking, diabetes, and hyperlipidemia. So high cholesterol. This is high cholesterol. This is one of the common causes of coronary artery disease. So there's a lot of terms. Sometimes they call them acute coronary syndrome. It's 3 things in one. So unstable angina, we talk about it, that somebody who has pain at rest. So pain at rest. Okay. That means it's unstable. It's about to turn into what we call MI. So the actual MI means complete occlusion initially, sudden. So this is the vessel and this is the plaques. Initially, they look like that. Then when something happened, okay, the plaques basically all of a sudden completely closes like that. So the heart sitting here is not, this is the heart, okay? And this is the portion of the heart, basically the muscle is not getting blood. And so it becomes something we call MI. It developed ischemia. That means tissue is dying and develop myocardial infarction. So they infarction is another way of calling ischemia. And there's 2 types. There's ST elevation and non-ST elevation. That means when the tissue start to die, when you get the EKG, I'll see if I can draw EKG briefly. When you get the EKG, you have the P wave like that. Then you have the QRS complex, and then the ST coming. So this is the S and this is the T. This ST goes up. So you have ST elevation here goes up. And that's how we can see whether you have MI. So and the 2 first one is ST elevation. Somebody will have symptoms consistent with myocardial infarction. But when you get an EKG, you will not see this ST elevation. So ST elevation, the right way to draw it is the ST go up and the T way of also go up. So this is ST elevation. So for that patient, they will develop ST elevation and the other one non-ST elevation. Both of them are MI, but one you don't see ST elevation, and that's the distinction. It doesn't matter. They are acute coronary syndrome is the MI. All you need to know is the MI. Something is dying, blood flow is not adequate. But in case you see these words, don't worry about it. It's the same thing. Angina, unstable angina can lead to stable MI, and the MI will be both ST elevation and non-ST elevation. So How do you manage them? You have a vessel going to the heart. Okay. Now that vessel is completely blocked. There's no blood flow. Okay. They will present to the emergency room and you expect them to have chest pain. So they come in, chest pain. You have to know the symptoms that they will come in with. And that's how you can tell. There's some classic symptoms. So classic and atypical. Sometimes they trick you with who do you see? Classic chest pain, which is MI. Okay, MI, they have left-sided chest pain that go into one. Left jaw, left shoulder, left arm. So you radiate along the hand, basically shoulder, the arm to the lower extremities completely. Sorry, the upper extremities. So from the chest to the shoulder and the rest of the upper extremities in the hand, the same side. Atypical is usually found in patients who have diabetes because they lack the peripheral neuropathy. They have peripheral neuropathy, so they don't feel the pain that they're supposed to. And secondly, you can see in elderly patients, so due to the sensation changes, and so diabetic patient doesn't feel the pain well, so they come in differently. So atypical. So don't get fooled. Anybody who have mid epigastric pain, they will have mid epigastric pain is elderly who is diabetic. He has nausea. They have diaphoresis. So they sweaty. Okay. They look tired, fatigue. You should worry. So far as they say they have chest pain, but it doesn't go to their jaw or anything like that, but it said they have nausea, diaphoresis, and fatigue. That's atypical presentation of MI. You should see that patient. That patient is a priority. So that's the two. Typical left chest, go to the left jaw, shoulder, and arm, and the other one, atypical elderly patient, diabetic. They have chest pain still. It's non-specific. They don't describe it sharp, dull, with some nausea, they're sweaty, they fatigue, and then they look sick. Yeah, that's MI for you right there. Okay, so treatment. We got to open the vessel. The vessel is clogged. We got to open it. And the tissue, the heart tissue is dying. Okay, this is the heart tissue. It's not getting blood. It's not getting blood. So we got to give him some oxygen. The reason why he's looking for blood is he need oxygen. So anti-thrombolytic. So the thrombolytic. That means you're breaking clot buster. You have to go break the clots. They will go to cardiac catheterization. There's three specific things that you need to know. People who need thrombolytic, if they have ST elevation, MI 1 and 2, if they are chest pain, it's less than 12 hours. Remember, if it's more than 12 hours, the tissue is dead. There's no need to open it anymore. So if it's less than 12 hours, and if they have no bleeding complication. So because what we're going to use is thrombolytic. So if they just have recent surgery, they cannot have it. If their blood pressure is uncontrolled, it's the same thing you do for stroke. Hypertension, uncontrolled hypertension, recent surgery, recent head injury, all of them, they cannot undergo thrombolytic. So you have to check. But the key thing is, once again, is wanna give them something, get the EKG and work them up. Make sure they have an IV, large bore IV, assess them, assessment, and then check for thrombolytic therapy indication. And that's the treatment for that. So before they go, they like most of them will be on nitrate. Okay, even after everything, they will take this medication home. This is a vasodilator. You have to know everything about this medication because a bunch of patients on it. It's a vasodilator. And then how does it look? It's usually it's a tablet. It can comes in tablet form. Okay, it can come in the what do you call it? Like a spray. They can spray it, and then it can come in the patch. So you have to know the usage of all of them. Okay, these medication, especially the tablets, they are usually very light sensitive. Okay, so light sensitive. So you leave them in the same container, stay in the container, and you don't take them out, and then avoid light. So you hide them in, make sure they are in your purse. You hide them from light. Okay. Is taking sublingual. You put it under your tongue. Okay, sublingual. No chewing. You don't chew. These are all facts you have to know because that's what you tell the patient. You don't chew this medication. You don't swallow it. You just put it under your tongue and it will dissolve. When they have chest pain, okay, at home, they should take one tablet or one spray and wait for 5 minutes, okay, because that's you take it every 5 minutes. If after the 5 minutes, no improvement or worsen, they should call MD and 911. They should call 911 now. Then they take another one while they're waiting. They shouldn't wait until they take 3 doses. You may read some books, they say take 3 doses before. It's too late. That's heart attack right there. So if they take one, wait for 5 minutes. If there's no improvement or it worsens, the pain worsens, they should call 911 right away. Take another one while they're waiting. So they can take 3 tablets, but it has to be 5 minutes interval. Okay, so they can take 3 tablets. That means in 15 minutes, they can take 3 tablets. But the key thing is this: they should not wait. When they have chest pain, you take one. 5 minutes later, check if there's improvement or there's no improvement. If there's no improvement, don't take another one right away. Just call 911 while you, as soon as you call 911 and let them know so that they can start moving, and then you can take the other one. That is the sequence. This is very important. Take one, call 911, then take another one while you're waiting. If they have not get there, you can take the third one. But that is the idea to the way to take nitroglyceride for this patient. Okay, it's very important you teach them that. If they have, okay, the in terms of the tablets too, or whatever spray they use, the patch, this is very important. 6 months. So they need refill every 6 months. So they get 6 months supply. So this is not a medication they give you every month. No, because if you run out of it, it's a problem. So you get the dose 6 months so that you have enough time to go back to to get a refill before it ran out. So 6 months supply. This is some medication that you can get 6 months supply as soon as possible. It's a vasodilator, so no other vasodilator. This is why they like asking you questions on this, because a lot of people are on Viagra, okay, which is what we call sildenafil, or they can have talendafil. They all have the last name Fields. The Fields, I call them sildenafils and talendafils. They all have the last name Fields, and those two are vasodilators. They are used for erectile dysfunction. It's very common. Okay, erectile dysfunction in older patients, because when they get older, things doesn't work well, so they will require this erectile dysfunction medication. Unfortunately, as you get older, you may have a heart problem and you may need nitroglyceride, and therefore you cannot combine both. If you combine, you have severe hypotension and you may die or heart attack. So cardiac arrest. And so they should avoid sildenafil group or any nitrate. Okay, they should also avoid alpha blockers, which is common in older patients because they also have problem urinating, because some of them have a BPH, and that help with the relaxation of the sphincters and allow them to pee. So one of the alpha blocker is this medication you have to know, taurazozines. They have last name as zines, or tumulocin. These are what we use for prostate, BPH. So BPH medication, taurazozines and tamoxifen, the FLOMAS. So basically one of them is a FLOMAS. So they open, I like to use the word, their name that they can put in the test. They don't use their trade name. So FLOMAS, taurazozine, tamoxifen, tomolocin is used for patients with BPH. Of course, older patients have BPH and that causes problem. So you tell them you can't take that. Okay, they're going to get headache. This is normal. Okay, expected finding. The one that you have to be sharp about is this: no vasodilator, no alpha blocker. Okay, because it's a vasodilator, the common side of vasodilator is orthostatic hypotension. So this is all expected finding that you expect them to have. So you know how to educate them. I told you about the patch, so you got to also know how to educate them about the patch. It's a once a day thing, okay? It has to be on 12 to 14 hours, not 24 hours, not all day, just 12 to 14 hours, then they take it out. They can only have one at a time. So one at a time. So if one fall off, you take the other one first, and then you put the other one. How do you dispose it? Very important, because there's kids around, there's dogs around. So you wear gloves, okay? You wear gloves. And when you take it, the adhesive portion of it, you fold it on itself. You don't expose the adhesive portion, because that's where the medication is. If somebody pick it on the floor, a kid put it on the floor, he stay on his finger and put his hand in the mouth, well, guess what? He's getting nitro, and that's bad. You don't want that. So that's something they can ask you in the question. Disposal is you take it and you fold it. You wear gloves. If you don't wear gloves, just wash your hand after you do that. The reason why is a patch, we don't want to absorb it too quickly. It's a slow release. That's what patches does. So the skin has to be clean, so no skin breakdown, okay? You shouldn't, there shouldn't be any skin breakdown. It should be completely clean. And so if there's any skin breakdown, tell them not to put it there. Because of that, you tell them no shaving. If you shave, you may break the skin and you put the patch in and it can't absorb too quickly. We don't want that. And then what? You have to rotate, because sometimes you can get erythema around the area. So rotation. So you put it in a different area all the time. This applied to most patches, rotated. And this is the question they will ask you. Okay, can I take a shower? Yes. The top portion of the patch is it has a friction, so it allow water to run over it without any problem. There's no medication. So shower is okay. So they can take shower. So these are teaching, and you see, don't be surprised when they ask these questions about patch treatment, teaching as a SATA question. You can predict what they're going to ask you. All these things, if you know, you golden. Okay, so that's how you do that in terms of patch education. So I think that is all and all. And then we will use one questions, then we'll be done for the day. The same thing, SATA. Which of the following need further teaching concerning nitroglyceride? So this is a SATA question. A client with the known coronary artery disease was seen in the clinic for evaluation. So he has a CAD, he's on nitro. So something that needs further teaching. I usually keep a bottle in my car glove compartment. Well, it shouldn't be on the light. Your car is parked outside. The sun is shining on it. The nitro doesn't work anymore. I will refill my prescription in 30 days. No, you get a 60-day supply, 60-month supply. So in 30 days, you don't need to refill. 60 months, you have enough time supply for 30. We don't want you to come every 30 days. Things can happen. So that's wrong. So this, you need further teaching. So sorry, you need further teaching. We check it. You see, sometimes you get it wrong, but then I went back and said, oh no. So this one to need further teaching. Even though it's need further teaching, if it's the wrong, that's the right answer. So you have to say it to your head. So we can also make that mistake. I will rise up slowly from a sitting position. Yeah, they get orthostatic hypotension. So this doesn't need further teaching. I will expect headache while on this medication. Yes, vasodilator doesn't need further teaching. My partner requesting I start using sildenafil. That means the wife wanted to start using Viagra. That's bad. Need further teaching. My patch will stay on for 24 hours if I decide to use it. Well, so you need to keep it on 12 to 14 hours. So have the duration. So that's need further teaching. So 1, 2, 5, and 6. So that's all. I hope I'm able to convince you about the importance of this disease and you learn something. Good luck in your studying and check my YouTube website and subscribe. Thank you very much.